Many drugs can alter the rate of hepatic clearance by changing factors represented by variables in the well-stirred model. These changes are most likely going to be due to alterations in intrinsic clearance, due to changes in biliary clearance, induction or inhibition of cytochrome P450 enzymes, or alterations in the activity of drug transport polypeptides. Alterations in hepatic clearance due to changes in drug protein binding are also a theoretical possibility, but those clearance changes are often offset by changes in the fraction of active drug or changes in volume distribution. When reviewing a patient's drug profile, it's hard to pick up on all the possible drug interactions. And in elderly patients, it's not unheard of for them to be taking 13 or more different medications. It would take a pharmacist a very long time to look up every possible combination. One solution would be to use computers to do the checking for us. The school has subscriptions to Lexicomp and Micromedics, both of which have built-in drug interaction checking programs. Let's analyze a drug regimen. We can put in the patient's drug regimen and then click Analyze. As you can see, a number of different potential drug interactions appear. The one that's labeled as being potentially most serious is atorvastatin and gemfibrozil, both of which are used to treat high cholesterol. Clicking on the link shows that gemfibrozil may make it more likely that the patient will suffer rhabdomyolysis, which is an adverse effect of all the statins. Also, we can see that there's good evidence that this interaction actually occurs. Further down, we see that the likely mechanism is gemfibrozil reducing transport of atorvastatin into the liver by inhibiting organic anion transport polypeptide. This might change the intrinsic clearance of atorvastatin, leading to higher concentrations. The interaction between carbamazepine and atorvastatin is due to atorvastatin being metabolized by the CYP3A4 enzyme. Carbamazepine is an inducer of CYP3A4, which would mean that atorvastatin would be metabolized more quickly and serum concentrations would be lower. Interestingly, we can see on this list that carbamazepine is also a substrate of 3A4. It's both a substrate of 3A4 and an inducer of 3A4. So does that mean that carbamazepine has a drug interaction with itself? Actually, it does. This is a phenomenon called autoinduction. When a patient is started on carbamazepine, we sometimes see a decline in carbamazepine serum concentrations after a week or two, even if we don't change the dose. It occurs because carbamazepine induces the same enzymes that metabolize it. The increase in enzyme activity caused by carbamazepine results in carbamazepine concentrations falling. Carbamazepine causes a drug interaction that only involves one drug. Carbamazepine and clarithromycin have a two-way interaction. Both drugs are metabolized by 3A4. Clarithromycin is an inhibitor of 3A4, which can cause slower metabolism of carbamazepine and thus higher concentrations. Carbamazepine is an inducer of 3A4, which increases metabolism of clarithromycin, leading to lower serum concentrations. Some drug interactions are not due to pharmacokinetic effects, but are just additive pharmacodynamic effects. For example, both carbamazepine and hydrochlorothiazide can decrease blood sodium concentrations. When we look at the interaction, Lexicomp warns us that when we are using two drugs that both can cause hyponatremia, we might see more hyponatremia. Then there are drug interactions which are intentional. The software warns us that adding hydrochlorothiazide to lisinopril can cause increased blood pressure lowering effects. Well, that's probably what the prescriber was trying to do by adding hydrochlorothiazide to the regimen, get a greater decrease in blood pressure. So it's an interaction, but it's a desirable interaction. In truth, many times these drug interaction warnings don't require us to do anything. For example, suppose a patient has been on the same doses of carbamazepine and atorvastatin for a long time without any problems. When the patient comes in to have their carbamazepine refilled, the warning about the drug interaction will likely pop up on the computer. However, at this point, the effect of the drugs on the cytochrome P450 enzymes and organic anion transport polypeptides has stabilized, and nothing further is likely to change. What's more important is when a drug is added or taken away from a regimen. If a patient is being started on a course of clarithromycin for an infection, we'd need to be concerned about the interactions with atorvastatin and carbamazepine. In that case, it might be prudent to check with the prescriber to see if a non-interacting antibiotic might be a better choice. As you can imagine, it takes time to review all these drug interactions, and many times they aren't clinically important. If you're a pharmacist filling dozens of prescriptions per hour, it's easy to suffer what's called alert fatigue, and just click through the warnings without paying much attention. Work is being done to make these alert systems smarter and assist the pharmacist in deciding which drug interactions are most important. But ultimately, it's the pharmacist's knowledge and judgment that need to be relied upon to protect patient safety.